So we'll start.
Okay, make it in slide. Hello, am I audible?
Yes, sir.
Okay, today we'll discuss about approach to Parkinsonism. As all of you know, Parkinson's disease is the most common neurodegenerative movement disorder due to the degeneration of dopamine producing neurons in the substantia nigra and midbrain. Classical triad would be tremor, rigidity, and bradykinesia. Along with that, many non-motor and neuropsychiatric manifestations will be there. So before going in detail, let us discuss what are the classification of Parkinsonism. So whenever you receive the Parkinsonism patient, you need to divide whether patient belongs to primary Parkinsonism or multi-system degeneration or associated with degenerative Parkinsonism or any secondary Parkinsonism. In primary Parkinsonism, as all of you know, idiopathic Parkinson disease is the most common and juvenile Parkinsonism is the second one. In multi-system degeneration, mainly you should know about progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, and Parkinsonism dementia complex. These are the multi-system degeneration you should be knowing. This is also known as Parkinsonism plus syndrome spectrum. And other degenerative conditions like Huntington's disease, Wilson's disease, Halloween-Spatz disease, spinocerebellar ataxias, CJDs, mitochondrial cytopathies, and neuroacanthocytosis. These are the commonly dealing degenerative Parkinsonism. And last one and very important is secondary Parkinsonism, because these are all reversible condition. You need to identify the causes. Most commonly in the infectious causes, post-encephalitic. Uh, Most commonly dealt virus would be arbovirus group like dengue, JE, all those will causes basal ganglia lesion that in results to Parkinsonism. Others are HIV, measles, CJD, that is prion diseases, and you need to inquire about the drugs like dopamine receptor blocking agents, that is antipsychotics, antiemetics, and methyl dopa, lithium, calcium channel blockers like flunarizine and synergine also causes Parkinsonism. And toxins like MPTP, carbon monoxide, manganese, mercury, cyanide, methanol, and ethanol do causes Parkinsonism. And other causes like vascular Parkinsonism due to progressive stroke or recurrent stapler like progression stroke that do also causes Parkinsonism. Traumatic, that is called pigalactic encephalopathy. Classical examples is Muhammad Jinnah. And other metabolic causes like parathyroid abnormalities, hypothyroidism, hepatolenticular degeneration, tumors, abscess, malignancies, normal pressure hydrocephalus, and syringomyeloencephalia, hemiatrophy, hemiparkinsonism syndrome, and last one is functional, that is psychogenic Parkinsonism. This is a gross classification of Parkinsonism. So whenever you see the patient having the Parkinsonism features, you need to rule out whether this patient belongs to typical Parkinson spectrum or atypical Parkinson spectrum. Atypical Parkinson's disease is also called Parkinson plus syndrome, that is PPS. Atypical Parkinsonism refers to group of neurodegenerative movement disorders that resembles idiopathic Parkinson's disease with certain distinguishing features depending on clinical, radiological, and pathophysiological features. Classical examples are multiple system atrophy, P, and multiple system atrophy, C, progressive supranuclear palsy, Lewy body dementia, corticobasal degeneration. Okay. Usually in this setting, patient will have rapid progression. Within 5 years of onset, patient will be bedridden. And most of the patients will not have typical motor features, sometimes associated with tremors like essential tremor spectrum. And in MSA, patient will be having severe bulbar symptoms like dysphonia, dysarthria, dysphagia, inspiratory stridors, and severe autonomic dysfunctions. And recurrent falls, that is more than one fall per year within 3 years of onset of Parkinsonism features. This is classically seen in progressive supranuclear palsy. And history of dystonia in the form of enterocolis seen in MSA. And absence of non-motor symptoms, like in case of dystonia, Parkinsonism spectrum, and pyramidal signs classically seen in progressive supranuclear palsy and MSA. This one is again the same flow chart. So whenever you are dealing with the Parkinsonism, you need to see for red flags always, because atypical Parkinsonism, that is Parkinson plus syndrome, will carry very poor prognosis, and drug response is also poor, and surgical intervention also not possible. So you need to ask cognitive dysfunction, any symmetrical signs, bulbar dysfunction, predominant gait disorders, falls within the first year of onset of Parkinsonism, wheelchair dependence within 5 years, early autonomic dysfunction, sleep apnea, riders, apraxia, alien limb phenomena, and cortical sensory loss. These are all the red flags. So in history also you need to ask, in examination also you need to confirm. Okay. So pathophysiology thought to be due to or TDP43 protein. So Parkinson dementia diseases, Parkinson disease, multiple system atrophy predominantly by alpha synucleinopathies, Lewy body dementia predominantly amyloid deposition, PSP and CBD predominantly tauopathies, and TDP proteins mainly in FTD, because all these degenerative diseases are associated with Parkinsonism. Next slide. So clinical feature, as I told earlier, we'll briefly see the other features also. In multiple system atrophy, patient will not have good response to levodopa. Only in 30% of the cases, patient will have benefit. And patient will have severe autonomic dysfunction in the form of orthostatic hypotension, erectile dysfunction, post-void residual urine in the first 5 years of the disease. And patient will be having nocturnal stridor, mark postural jerky tremors in the form of mini poly, myoclonus, anterocollis, and orofacial dystonias. These are all red flag for typical Parkinsonism and classical features of multiple system atrophy. Akinetic rigid Parkinsonism features, and usually signs will be symmetrical, poor levodopa response, and patient will be having vertical saccade slowness and supranuclear down gaze palsy also. Patient will be having square wave jerks, and levator is inhibition that will causes that omega sign, that is facial dystonias associated with blepharospasm, pseudobulbar effect, early dysarthria, falls, and gait freezing, and associated with predominant frontal kind of dementias. And other one is corticobasal degeneration, in which patient will be having asymmetrical akinetic Parkinsonism, hemiparesis, hemisensory symptoms, cortical sensory loss, alien limb phenomena, limb apraxias, focal myoclonus, along with frontal lobe spines. Okay, these are all the spectrum of diseases belongs to Parkinson plus group of diseases. So this is a similar slide you go through once finishing the class. Okay, next slide. So let us come to the typical, that is idiopathic Parkinson's disease. This belongs to typical group of Parkinsonism. We'll study first this one. So etiopathogenesis predominantly thought to be environmental factors or toxin or endogenous factor or sometimes genetic mutations that will lead to abnormal accumulation of the protein, oxidative stress, mitochondrial injury, finally leading to the apoptosis of dopamine producing cells in the substantia nigra and midbrain that will lead to the Parkinson's disease. So similar slide, that is oxidative stress, mitochondrial failure, excitotoxicity secondary to glutamatergic neurons, protein aggregation, transport problems, DNA transcription problems, and inflammatory markers like nitric oxide excess, apoptosis, and infection. So already we discussed about the typical Parkinson symptom, that is trap, tremors, bradykinesia, rigidity, or akinesia associated with postural instability. Initially, it used to start with the one side, that is asymmetrical onset will be there. And other causes like non-motor symptoms like depression, dementia, dysphagia, anxiety, orthostatic hypotension, constipation, anosmia, all are the associated symptoms. Okay, you need to inquire these symptoms also. So Parkinson's disease will be having the course, that is prodromal symptoms and the typical clinical symptoms. In prodromal, again patient will be having, again you can classify that the non-motor and motor symptoms will be very less in the prodromal state. Patient will be having REM behavioral REM behavioral sleep disorders, excessive daytime sleepiness, hyposmia, constipation, hypotension, erectile dysfunction, anxiety, depression. These are all the earliest prodromal symptoms of the Parkinson's disease. Once the motor symptoms start, that time only we come to know that patient is having uh, typical Parkinson's features. So whenever you are dealing with the Parkinsonism, you need to inquire these prodromal symptoms also. Or otherwise, if the patient comes to your OPD with these complaints like RBD, excessive daytime sleepiness, autonomic dysfunction, you need to uh, keep an eye regarding the motor symptoms also. And this is the earliest features of a Parkinson's onset. So once clinical features set in, patient will be having typical trap symptoms and fluctuations. As the duration progresses, patient will have fluctuations, dyskinesias, postural instability, and gaze disorders, dysphagia, and associated mild cognitive impairments also. So as the time progresses, patient will end up in multiple problems. So let us come to the diagnostic criteria of Parkinson's disease. You should be knowing this criteria. This is also known as United Kingdom Parkinson's Disease Society Brain Bank criteria. Okay, this one you should be knowing. For atypical Parkinson's disease also, so many criteria are there. That is not for PGs. Just you remember the typical Parkinson's disease diagnostic criteria. So to tell idiopathic Parkinson's disease, there are three steps. In step one, patient will have classify under Parkinson's disease. This is the mandatory criteria for any Parkinson's. Okay, and associated with one of the symptoms, that is rigidity, rest tremors, and postural visual problems, vestibular problems, cerebellar problems, or any sensory ataxias. Okay, this is step one more part. In step two, you need to exclude the other causes of Parkinsonism because so many causes like head injuries, encephalitis, drugs, genetic Parkinson's, and associated atypical Parkinsonism features, dementias, all those things to be inquired. Because if patient is having along with these symptoms, you cannot classify the patient as idiopathic Parkinson's disease. So it will come under secondary Parkinsonism or heredodegenerative conditions or multiple system, that is multiple system atrophy related Parkinsonism. So you need to exclude all these causes. So whenever you are labeling the idiopathic Parkinson's disease, you need to exclude all the causes. And third one, supportive features. In these supportive features, patient should have at least three. That is asymmetrical onset, rest tremors, progressive disorder, persistent asymmetry, and well response to the levodopa. And sometimes patient will have levodopa-induced dyskinesias and more than 5 years of sustained levodopa responsiveness. And disease course will be more than 10 years, unlike in atypical Parkinsonism. Among these, patient should have at least three features, and you need to exclude the secondary causes. And primary criteria, patient should have bradykinesia. Okay, you should remember these criteria. So this is the risk factor: age, family history, pesticides, head injury, REM behavioral disorders, constipation, depression. These are most likely patient will develop Parkinsonism in future. Okay, as textbook says, caffeine and cigarette have decreased risk and should not be used as therapeutic. Okay, just you remember some most of the studies shows caffeine intake and cigarette smoking will decrease as the Parkinson's disease risk. Okay. So prognosis would be like initial 5 years, patient will be having good response to levodopa. That is also known as honeymoon period. In between 5 to 10 years, patients start having medication-related difficulty, that is motor fluctuations, dyskinesias, weaning up phenomena will develop in 5 to 10 years. So after 10 years, patient will start having postural instability and disease progressive, patient may bedridden. So genetic, you remember just name of gene, that is Park genes predominantly. Park gene, again, they have classified as 1, 2, 3, 4, up to 22 they have given. Just you remember the gene name, Park gene, because individual gene mutation will have a separate kind of clinical features. This is for, I think, DM resident. You remember just gene names, Park gene, okay? So secondary causes, as a physician, as a medicine resident, you should always be knowing secondary Parkinsonism, because in emergency, most of the people will see these kind of causes. The drug induced are most commonly, that is psychiatry follow patient develop the Parkinsonism, most commonly secondary to the antipsychotic drug, vascular Parkinsonism, toxin, predominantly copper and manganese induced basal ganglia lesion, that too also causes Parkinsonism. Infections like toxoplasma, cryptococcus, tuberculosis, especially in the setting of immunocompromised status, CJD will also causes Parkinsonism. And autoimmune causes like DPPX, NMDR, Isilon antibody mediated autoimmune encephalitis also causes Parkinsonism. And last one is neoplastic, like direct invasion or secondary to paraneoplastic manifestations of the malignancy. Patient will have Parkinsonian features. Others like metabolic, like copper metabolism, sugars, calcium metabolism, magnesium metabolism will also have, and iron metabolism also. Patient will suffer from the Parkinsonism. And other is normal pressure hydrocephalus. And last one is functional. These are all the secondary treatable conditions. So before labeling into typical or atypical Parkinson's disease, kindly look for secondary causes, because all these are reversible. So you need to identify in the initial part of the disease. So this is the staging of Parkinson's disease. Just you remember the name, when as scaling, in which in stage 1 patient will have only unilateral symptoms, stage 2 bilateral symptom without impairment of the balance, in 3 mild to moderate disease and some postural instability but independent. In stage 4 patient will be dependent and need assistance for the routine activities, and stage 5 is bedridden. Okay, whenever you are writing diagnosis, that is typical Parkinsonism, idiopathic Parkinson's disease, when R scale 1, 2, 3, 4, 5. So whenever writing the diagnosis, you do mention stage of the Parkinson's disease. Okay. Usually, most commonly, diagnostic cells are not beneficial. This is for like to rule out the secondary causes. UPSID, that is University of Perisylvanian smell identification test. These are the standardized kits. From that, we can identify the um, smell, and we can label the hyposmia, typically which is seen in the Parkinson disease. So olfactory dysfunction also, prodromal symptoms, uh, we can identify by these examination kits. Okay, and imaging most commonly to rule out secondary Parkinsonism. Like if the patient is having acute or subacute onset Parkinsonism, symmetrical symptoms associated with the systemic complaints, in that setting, you need to rule out secondary causes by doing the MRI. And degenerative conditions like multiple system atrophy and PSP also, we can see some signs like putamen atrophy, putamen rim sign, cerebellar peduncle atrophy, heart crust burn sign, classically seen in multiple system atrophy. And in midbrain atrophy, that is hummingbird sign and morning glory sign, can be seen in progressive supranuclear palsy. So typically we can see, but not in all the cases. So mainly MRI imaging are for to rule out the secondary Parkinsonism. Okay. And Dopa PET scan can be used to diagnose the Parkinson's disease from the other degenerative Parkinsonism. Okay. Again, functional scan, the PET scan can be used to rule out other causes like associated corticobasal degenerative conditions, progressive supranuclear palsy. In that, uptake will be less in the frontal lobe in the setting of progressive supranuclear palsy. And in parietal hypometabolism, classically seen in corticobasal degeneration, we rarely use to diagnose uh, these kind of Parkinsonism, because most of the diagnosis would be by the clinical history and examination. And genetic testing can be opted in a patient, those who having a family history or young onset Parkinson's disease. In that setting, we can order for genetic testing also to see for the PARC gene mutations. So this is the Doppler PET scan. Here you can see there is asymmetrical decreased uptake in the basal ganglia, classically seen in idiopathic Parkinson's disease. This one and here. Okay. And multiple system atrophy, classically you can see pontine and cerebellar atrophy. In SAS, you can see pons and cerebellar atrophy. And one sign is there, it is heart crust bun sign. In multiple system atrophy, selective involvement of pontine transfer fiber that looks like a heart cross bun. You can see now here heart crust bun sign. This is and putaminal hypodensity. These are all the classical signs of MSA. Cannot be seen in all the patients. So just whenever you see the patient of multiple system atrophy, kindly go through the MRI and look for these signs. Okay. And progressive supranuclear palsy, in which selective midbrain atrophy will be there, disproportional to pons. Here pons is preserved, midbrain is severely atrophied, so it looks like a hummingbird. Okay, this is also called as hummingbird sign. And interpeduncular system, prominent interpeduncular system will be there because of atrophy of the tegment of the midbrain. The prominent interpeduncular system you can see, and sometimes periaqueductal hyperintensity is also marked. And putaminal atrophy, this is also called putaminal rim sign. This can also be seen in PSP. This is morning glory sign. Usually in the tegmentum of a midbrain should be ideally convexity should be there. Here due to the atrophy, tegmentum is completely burned out. So this looks like a morning glory flower. This is also known as morning glory sign. So morning glory sign is different and morning glory is different. Okay. Next slide. And other, this is in corticobasal degeneration, there will be significant atrophy of precentral and postcentral gyrus and hypometabolism also seen in the PET scan. So this is also diagnostic of corticobasal degeneration. Selective asymmetrical parietal lobe atrophy will be seen in CBD. So other degenerative condition, that is neurodegenerative diseases of the brain due to the iron accumulation spectrum. This is also called NBIS spectrum disorders, in which there will be accumulation of the iron in the various brainstem, putamen, basal ganglia, and in SWI images also you can see deposition of the iron. So these are all the NBI spectrum of this. Just you remember the name NBIS spectrum. This is also causes early onset Parkinsonism and predominant neck dystonias. And Wilson, as all of you know, patient will be having basal ganglia and thalamus, midbrain, and pontine hyperintense signal changes. Okay, so these are all the Wilson is the reversible causes. Whenever the patient, young patient, less than 40 years, presented with Parkinsonism along with the dystonia, always you should rule out Wilson, because by the medicines you can almost reverse the condition. So let us come to the treatment. So pharmacological treatment is very extensive. So we need to know when to start, what are the drugs to be opted, and how to start the drug, how to taper the drugs. Okay, there are multiple options are there: dopaminergic drugs and muscarinic antagonist, A2A antagonist, NMDA antagonist, glutaminergic, and serotonergic drugs also used in the treatment of the Parkinson's disease. So most of the treatment depends on the patient's symptoms, stages of the Parkinson, functional disability, and physical activity of the patient. Okay, so various pharmacological, non-pharmacological, and surgical treatments are also available for the treatment of both motor and non-motor function, non-motor symptoms of the Parkinson's disease. So treatment mainly divided as non-pharmacological, medical, and treatment of the motor fluctuations, treatment of the dyskinesias, and some surgical intervention and management of the non-motor symptoms. Okay, let us go by one. So initially the thought was any role of antioxidants or any minerals would benefit in the Parkinson's disease. So many studies have been done, that is Data Top and Leaf studies have done. They concluded that there is no role of any antioxidants or any neuroprotective agents in the management of Parkinson's disease. Like any disease modifying drugs in the Parkinson's disease, there are no role of any antioxidants or any neuroprotectives in the prevention or prevention of the progression of Parkinson's disease. Don't give any antioxidants. And initial some of the studies shows like levodopa that do causes mitochondrial and lysosomal dysfunction, leads to the synuclein accumulation and leads to the worsening of the Parkinsonism. Initial few studies shown, but later after doing the L-DOPA study, they concluded that there is no harmful effect of levodopa. Even we can start early part of the disease also, they have concluded. Okay. So two things you should be knowing. There is no role of any antioxidants or neuroprotectives in the Parkinson management, and there is no harm to start levodopa in the early part of the disease. Okay. So physical therapy and nutrition is also important. Next slide. In physical therapy, we can advise the exercises for rigidity, flex the posture, and better would be the regular aerobic exercises. Yoga and stretching exercises will help you to decrease the rigidity and posture, and it will help you in the management of anxiety and the depression. And physiotherapy is very important. That will improve the patient balance, flexibility, and brisk walk, swimming, and water aerobic exercises will also helpful. Multidisciplinary rehabilitation, physical therapy, and occupational therapy is very important. Treadmill training also helpful, and balance training and high intensity resistance training also helpful in the management of Parkinson's disease. And other exercises like agility training, cued exercises, music therapy, dance therapy will also decreases the rigidity and axial rigidity, and patient balance will also improve by doing these activities. Next is nutrition. There are no consensus. High fiber diet, adequate hydration exercise will help you to the management of constipation in Parkinson's disease. Sometimes in high fat meals or high protein meals interfere with the absorption of the levodopa. Better you avoid the high fat meals. Okay. Mediterranean diet and DASH diet you might be knowing. I don't go through in detail. These to be followed. And dietary protein restriction is not necessary in the initial part of the disease. As the disease progresses, that is later part of the disease course, patients start having motor fluctuations or dyskinesias. That time, if you give high protein diet, that will interfere with the absorption of the levodopa. In that setting, better you avoid high protein diet. Okay, in the later part of the disease, or patient those who having motor fluctuation, better avoid high protein diet. Let us come to the medical management is very important. You need to address both motor and non-motor function. One scaling is there, UPDRS scaling, that is Unified Parkinson's Disease Rating Scale. This is available in Google free of cost. This contains 4 parts, included both patient complaints and the examination findings. It have like 0 to 199 points. More the number, severe the disease. So whenever you start the medicine, you should do always baseline UPDRS score. So subsequently during the OPD visit, you need to calculate. So improvement or decrement, depending on the values of a UPDRS score, you need to escalate or de-escalate the dopaminergic therapy. Okay, UPDRS, just you Google it, you will get the PDM. Okay. So drugs, pharmacologically, it has classified as 3 drugs, that is classical levodopa, non-ergodopaminergic agonist, monoamino oxidase inhibitors, and last one is amantadine, and some anticholinergic drugs also come under the medical management of Parkinson's disease. Most potent drug would be levodopa, followed by dopaminergic agonist, then followed by monoamine oxidase. MAO-B inhibitors are least potent and least efficacious compared to other group of drugs. Okay. This is the drug list. Dopaminergic agonist, most commonly we use pramipexole, ropinirole, rotigotine, and apomorphine. Pramipexole, usually we need to start with low dose, that is 0.125 milligram. TDS you can start. and gradually over a period of 1 week, you can double the dose up to 4.5 milligram you can give. And once the patient dose is stabilized and side effects are minimized, you can directly shift to extended release. Say, for example, if a patient is taking 0.125 TDS, you can make it as 0.375 extended release tablet once a day. So after 2 to 3 week of escalation therapy only, you shift into extended release tablets. Okay. Same other drugs also. So main predominant side effect would be leg swelling. Patient will start having leg swelling. So whenever patient on dopa agonist comes with the complaints of leg swelling, don't evaluate extensively for the other causes. Okay. If a patient is having leg swelling, you need to optimize the dose, or you can see for the alternative drugs. Okay. The second would be levodopa preparation. You can start with a low dose like 125 mg, that is 100 bar 25 preparations are there. Half TDS or half BD. Gradually, you can escalate over a period of 1 or 2 weeks till 1000 mg. As textbook says, up to 2 grams also we can see we can give. Meanwhile, you need to see for orthostatic hypotension and GI symptoms also. And in higher doses, patients sometimes may develop dyskinesias also. Okay. In levodopa extended release tablet, if a patient is having severe early morning symptoms, early morning stiffness, in that setting also you can give extended release tablet in the night. This will come as 250, 500 preparation. Okay, you can start with 250 mg night once extended release tablet. And levodopa gel intestinal infusions are very rarely used because the cost of this infusion would be 30 to 35 lakhs per annum. In Indian setting, it would be very difficult. Levodopa inhalation powder, I think it is not available in India. Okay. Next. Next, come to the COMT inhibitor. This will help you to prolong the action of levodopa. Like other drugs, it also increases the duration of actions of levodopa. It can be given along with the dopamine supplementation. Entacapone is available in the form of 100, 200 mg preparations are there. You can give TDS or QID along with the levodopa. Predominant side effect would be again dyskinesias and pain abdomen. Sometimes urine color may changes to orange. Okay, so whenever you're giving the entacapone as like your ATT drug, this also causes change in the urine color to orange. Don't be panic. Just you counsel them that drug will causes these kind of symptoms. Okay, tolcapone, this is like due to the hepatotoxicity, not routinely using. So let us come to the MAO inhibitor, that is rasalazine, celazelin, and safinamide. As rasalazine preparations like 0.25 mg, zero point 0.5 and 1 mg preparations are available. You can start with a low dose, that is 0.25 mg. You always start MAO inhibitor only OD dose, better in the morning, because these have intrinsic amphetamagnetic activities and disturbs the sleep. So better you give in the morning, OD dose, start with a low dose, that is 0.25 mg OD, you can go up to 1 mg. Celazelin, better you start with 2.5 mg, you can go up to 5 mg. Predominant side effect would be insomnia and dizziness. Okay, safinamide, again you can start with 50 mg OD and gradually over a period of 7 to 10 days you can escalate up to 100 mg. Amantadine, plain immediate release or extended release preparations are also available. It will be helpful predominantly in tremor dependent Parkinsonism or levodopa induced dyskinesias. Predominant side effect would be again limb edema, skin changes, and hallucinations, confusion. So elderly, better you give on the lower dose, that is less than 100, 50 mg BD you can give. If young patients having symptoms, you can give up to 300 mg. So elderly patient, lower the dose. Young patients, you can give up to 300 mg. Osmolex is nothing but amantadine only. Other company, extended release preparations, is available in 62.5, 274, 129, and 258 mg. Extended release tablets are also available. Trihexyphenidyl, as all of you know, that is THP, Pacitine or Parkin tablet brander. Up to 8 mg you can give. Predominantly can be useful in the tremor dependent Parkinsonism, and tremors, it is not controlled by any dopaminergic drug. In that setting, we can use. Mainly side effect would be cognition, urinary retention, and blurring of vision. So better avoid in elderly patient those who are having urinary complaints and cognitive complaints. Botulinum toxin can be used in the focal dystonias. So next question would be when to start. For all the patient we need to start, or should we have to wait? It mainly depends on patient activities of daily living. You need to ask daily ADL whether these symptoms, tremors or rigidity or postural instability, affecting his routine activities for the work, social or leisure activities, and predominant affecting symptoms in the dominant hands and significant bradykinesia, gait disturbances. If patient prefers want to take the medicine, that is also considerable. Okay, so first you ask the ADL, dominant limb functions, associated other trap symptoms, and patient values also. So if it is all symptoms are okay, means you can start with the medicine. So what to start? The multiple debates are going on. So NICE and PDMed studies suggest that better to start with the levodopa, and multiple studies gives multiple opinion. We have to see the patient severity, age. Depending on that only, we can give the appropriate medicine. So all the patients, those who are having PD, should offer levodopa preparation because it also help you to diagnose in the diagnostic criteria. Also, you can if you are having any doubt of Parkinson's disease, you can give the you can do the first baseline UPDRS scaling, give the levodopa 125 or 250 mg. You assess the UPDRS scaling after 30 minutes. If patient improving more than 30% of the baseline score, this will help you to diagnose the condition also. So all the Parkinson's disease give a trial of levodopa preparation. And there is no significant difference of benefit between the dopamine agonist versus monoamine oxidase inhibitor. When you choose as a initial therapy, levodopa would be the most potent and efficacious drug, followed by dopa agonist, followed by MAO inhibitor. Anticholinergic can be used like benztropine or trihexyphenidyl in a tremor predominant Parkinson's disease. Okay, in other cases, it would not be helpful. So, what are the drugs to be given? Say, for example, if a young patient having very minimal tremors in a one hand and not affecting too much his routine activities, because monoamine oxidase having very least side effect and least potent drugs. In that setting, you can give only monoamine oxidase inhibitors like resalazine, selazine, or safinamide. If a young patient having risk of dyskinesias like younger the age of onset, lower body weight, female sex, in that patient will be having more chances of dyskinesia if you directly start with the levodopa. So in that setting, better you need to start with dopamine agonist. These have good potency and good efficacy and least side effect of dyskinesia. In this setting, you can start with dopa agonist like ropinirole, pramipexole, or apomorphine. Okay. And amantadine monotherapy can be given if a patient is having tremor predominant Parkinson's or patient is having levodopa induced dyskinesias. So mainly the choosing the drugs based on the patient characteristic like age, comorbidities, severity, drug efficacy, and the side effect. All those things you need to see whenever you want to start the drugs in a Parkinson's patient. So as I told earlier, tremor predominant PD, better give amantadine, anticholinergic. Even after that also patient is having refractory tremors, you can tell the option for deep brain stimulation or focused ultrasound. This will be helpful as a part of surgical therapy. So when you want to start dopa receptor, as I told earlier, young age of onset, lower body weight, female sex, and those who having higher risk of dyskinesias, better you start with the dopa receptor. Okay, because these have least motor abnormal side effects compared to levodopa. Okay. To swallow, like say for example, if a patient is posted for OT, patient should keep in the nil per orally. In that setting, if a reference come from the other surgical branches, uh, other oral drugs and upper
Hello, sir.
Okay. So if a reference from surgical branches and oral medicines are contraindicated, in that setting you can use roticotin patches or apomorphine injections. Okay. So we should be knowing the cost of therapy, because in our setup and government hospital, like dopaminergic agonist pramipixole, that will cost per 10 tablet, it will cost around 65. So patient need to take 3 tablets per day. So 90 tablets will cost around 190 to 200 rupees. So you need to see for the cost of the drug also. So least and least cost with most potential drug would be levodopa, that is 20 rupees per 10 tablet you can advise. And the most costliest would be apomorphine injection. For 100 mg 20 ml injection, it costs around 13,000. Okay. And deep brain stimulation in a government setup in Niman's hospital, they are doing in a 15 to 20 lakhs. In private sector, it will be around 30 to 40 lakhs. Okay, intestinal gel infusions, again, it is 30 to 40 lakhs. So you need to see the cost also whenever you are prescribing. If the patient is poor, not upper double, better you give simple levodopa preparation. Okay, next slide. So this is the approach. So after diagnosing D, if you are having any doubt, you can opt for dopaminergic or dopa PET scan. In that also, if it is negative, so you need to see for other alternative diagnosis. So we establish the diagnosis based on the clinical and investigation. See for the impairment. If a patient has very minimal symptoms or very least symptom, then you can advise the non-pharmacological therapy. If the patient really willing for the drugs, you start with the MAO inhibitor for least side effect with the least potent drugs. Okay. If a patient is having motor impairment that is affecting the day-to-day activities, in that setting, you can directly start with the levodopa, because in elderly MAO inhibitor and dopa agonist, the side effects are more. So in that setting, you can directly start with the levodopa. Okay. In a mild symptoms, young patient, in that setting, you can opt for both MAO or dopa agonist. After giving these drugs, again, patient is having still symptoms and progression of the symptom, you can escalate the dose of the levodopa. So after escalation of the dose, as textbook says, up to 2 gram levodopa can be given per day. Meanwhile, you should monitor the side effect. If the patient tolerating the dose, you escalate. If patient not tolerating, or after reaching the maximum dose also, patient is having Parkinson's symptoms, you can add on the drugs like COMT inhibitor, dopa agonist, or other newer drugs like apomorphine or strobilin. Okay. Even after that also patient is having severe motor complication, you need to tell the patient regarding the surgical intervention. Okay. So this is the same slide. Early stage, no symptoms, don't treat. In mild stage, start with the non-dopa therapy. If patient having symptoms, then give. In a moderate stage, even after giving the dopa agonist or MAO inhibitor, patient is having symptoms, means you can give the low dose levodopa or escalation of the dopamine. In advanced stage, patient will start having the complications like dyskinesia, motor fluctuation. That time you need to give the add-on drugs. End stage, again, patient will be bedridden, poor response will be there. In that setting, it is very difficult to manage the Parkinsonism. So come to the drugs. Most commonly we use levodopa in our clinical setting. So you should be knowing the detail about the drugs. Okay. So better you advise the patient to take in the empty stomach, because levodopa, it is a protein preparation. If you give along with the food, there will be decreased efficacy or absorption. If patient is tolerating, give in the empty stomach only. If patient is having very severe nausea, vomiting symptom, in that setting, you can tell the patient to take in after food only. Okay. Better avoid high dose protein, like any high calorie protein or high calorie meals. And if a patient want to take a tablet with a carbonated drink also, it can be given. Crushing the levodopa tablet with a carbonated drinks like soda, that will also increases the absorption of the levodopa. Okay. This option can also be given to the patient. So initial first 5 years, there are less complications related to the drug. Once the time passes, like after 5 years of the onset of the Parkinsonism, patient will started having the side effect. Okay, so better you start with the minimum dose in that patient having good symptomatic benefit. That one should be continued. Don't give unnecessarily extra dose of dopamine. So most effective drug would be levodopa, as all of you know. So meanwhile, you need to see for other complication of early weaning up, not attaining the on, and early dyskinesias. You need to see, and you need to explain the patient regarding future complications of levodopa, like dyskinesia, should be explained to the patient whenever you are starting the drugs. So better you start with the immediate release drugs, because sustained release drug will cause dyskinesia. So better you start with the immediate release a tablet, that is Syndopa or LCD or Cinamet. All those things are preparations. So better use immediate release tablet initially. So doses would be 125 mg preparation, that is 25 mg carbidopa and 100 mg levodopa. Start with the half tablet for 3 times a day. After a week, you can gradually escalate the dose. And meanwhile, you need to check for the UPDR scaling. So once the UPDR scaling, rate scaling goes on improving, means you need to decrease the dose. If the UPDR scaling worsening, means you need to increase the dose. Okay, lowest possible dose at which patient symptomatically better should be seen and should be addressed accordingly. And most of the patient will have benefit between the dose of 300 to 1000 milligram, and you should not stop syndopa abruptly, because it will causes Parkinsonism hyperpyraxia syndrome, in which patient will have severe akinetic rigid status, fever, almost it look like a neural malignant syndrome. So you should always inform the patient, like, no, I should not stop the drug abruptly. So before emptying the drug only, patient should come to the hospital and have to take the medicines. Okay, you need to explain the complication of sudden withdrawal of levodopa. Okay, other drugs like monoamino oxidase inhibitor and COMT inhibitors can be done to the levodopa, or can be given as a monotherapy for mild symptoms. And can be useful in adjunctive therapy in the treatment of motor fluctuations, or add-on therapy can be used. So already we discussed about these drugs, rasalazine, salazine, and safinamide. And salazine has good effect, like it has amphetamine metabolite. It will decreases the daytime sleepiness. So if a patient is having excessive daytime sleepiness, better you give salazine in the morning. Okay, so that will take care of your Parkinsonism and excessive daytime sleepiness also. Okay, it will be available in 2.5 mg and 5 mg preparation. Same as I told earlier, already I think we discussed the drugs. Okay, next slide. Next. Okay, like direct acting dopamine agonist, as I told earlier, propranolol, apomorphine can be used as an add-on adjunctive therapy. Okay, especially it would be helpful in the dyskinesia patient. Next, this drug, I think I have discussed the drugs. Apomorphine. Okay, we'll discuss this one. Apomorphine is an injectable preparation. This is 100 mg for 20 ml preparation is available. It costs around 13,000 for 100 ml. So it can be given intravenous, subcutaneous, sublingual, intranasal also there. But the main disadvantage is very short acting. So it can be useful whenever like sudden weaning off, sudden freezing, sudden off phenomena occurs. That time you can give as a bolus injectable dose. So every second early you need to give up to maximum per day you can give up to 30 mg. So per dose you can give 10 mg. So in children and adolescent it is not recommended. Okay, every second early you can give in a divided doses. Maximum single dose would be 10 mg. Okay, per day it would be 30 mg. Amantadine, this is NMDA, glutamate receptor antagonist. The dose would be 100 mg daily. In young patients, you can give up to 300. Elderly, better you give up to 100. Tremor dependent PD. and Parkinson's disease associated dyskinesias, in that setting, it would be much beneficial. Anticholinergic, as I told earlier, tremor dependent PD. If a patient is having Parkinsonism along with rigidity and dystonia, in that setting, you can use the anticholinergic. Only side effect is cognitive decline, hallucination, and urinary retention. So you need to monitor these complaints whenever you are giving in the elderly patient. So this is a chart that if you give the early levodopa, patient will be having less disability and higher chances of dyskinesias in the future. If you use the levodopa sparing strategy, patient will have high early disability but least dyskinesias in the future. So choose the drug appropriately, choose the less dose in the initial part of the disease to prevent the future levodopa induced motor dyskinesias. So this is the very important motor fluctuation management after diagnosis and starting the treatment in the Parkinson's disease. Okay, there are the following mentioned are motor fluctuation. Most common would be weaning off. Second one is the unpredictable on and off, freezing, sudden freezing of gait, delayed on response, and early morning akinesia or bradykinesia. These are commonly seen motor fluctuation. We'll see how to manage these conditions. Okay. Weaning up means that is this is the most common motor fluctuation. The effect of the levodopa will be ceases just before or in the advance compared to the next scheduled dose. Say for example, levodopa usually it do act for 4 to 5 hours if you go the dose. After the some duration, after some years, patient will have effect for a duration of only 2 hours, and patient will land up in the off phenomena. That is called weaning off phenomena. Okay. And other is sudden on and off episodes. This can be seen in Parkinsonism at any time due to the alteration of the drug level in the body. And sometimes patient will not get the on. It will because levodopa is very short acting. After taking the tablet, within 15 to 20 minutes, patient will have symptomatic betterment. But in the setting of motor fluctuation, patient will not have early on. So that is called delayed on, in which prolongation of the time required to act the anti-Parkinsonism drug to produce the effect. That is called delayed on. Okay. Last one is dose failure. Even after giving the complete dose and duration also, patient will having off phenomena. This is called dose failure. So most commonly we see wearing off phenomena and delayed on phenomena. We'll see how to manage this condition. Say for example, delayed on is there. You have given the tablet till patient is in the off mode. In that setting, what to do? You need to increase the dose of the levodopa. Okay. Say for example, if you are giving 125 mg QID, even after taking 125 mg, also patient is in off mode. In that setting, you can increase the dose to 250 mg. Okay. This is the delayed on management. And second one is early morning akinesia. If a patient is having severe symptom in the early morning, not able to roll over on the bed, not able to go to the washroom, and not able to do the brushing, not able to have the tea in the early morning. In that setting, you need to give extended release or control this tablet at the bedtime, or you can give rotigatin patch in the night, or you can give early morning apomorphine injection. So this setting, in this setting, patient will be having early morning akinetic symptom. In that setting, you can use control release levodopa tablets. Third setting would be end of dose weaning off. So you are given the tablet, uh, stopped acting after 2 hours. Like ideally, it would act up to the 4 hours. So later part of the disease, the effect will wean off very early. In that setting, you need to increase the frequency. Say for example, you are giving 3 times a day. You make it 4 times. You make it 5 times, or you make it 6 times. Okay, so you can increase the frequency of levodopa so that you can treat the end dose effect. Okay, or you can add long acting levodopa preparation, or you can add COMT inhibitor, MAO inhibitor, or dopa agonist in the dose weaning off phenomenon. In the setting of unpredictable on and off, better options would be apomorphine injections or your surgical intervention. If a patient is having frequent episodes of freezing, you need to address therapist regarding physiotherapy and occupational therapy. Okay, and gait therapy also. Any doubt in this slide? This is very important. Frequently, you might be
Sir, what is end of dose weaning off, sir? Can you repeat?
Weaning?
End of dose weaning off, sir. Can you repeat that, sir, once again?
End of dose means we are given levodopa tablet. Ideally, levodopa tablet will act for a period of 4 hours. So as the disease progresses, the duration of action of levodopa will also decreases. Rather than 4 hours, the effect of the levodopa ceases only by 2 hours or less than that also. In that setting, you need to increase the frequency of levodopa. Early weaning of the dose effect, that is weaning off, end of the dose effect also.
Okay.
Delayed on means like the half-life of levodopa is very less. So you give the tablet in a 15 to 20 minutes, it should act. So in a patient with Parkinson's in the late disease, the levodopa will not start act early. So in that setting, you need to give the little higher dose. Like in place of 125, you give 250 mg dose, so that on will occur. On means normal, off means that is Parkinsonism symptom. Just you remember on and off. On is normal phenomena, off is Parkinsonism. Okay.
Okay.
Okay. Dyskinesia, this is also very important. So whenever the disease progresses due to the hypersensitivity of the dopa receptors in the basal ganglia, even sometimes fluctuations of levodopa in the serum that will causes abnormal movements. It may be chorea, dystonia, or so multiple mixture of movements will be there. That is called dyskinesias. Most commonly we see in the later part of the disease or young onset Parkinsonism. So there are 3 types of dyskinesias are there. One is peak dose dyskinesia. You give the tablet, within 30 minutes of giving the tablet, patient will start having abnormal coriform or dystonic movement. This is called peak dose dyskinesia. Next, diphasic dyskinesia. Like in the on period also patient is having dyskinesia. In the off period also patient having dyskinesia. On means normal, off means Parkinsonism. Even Parkinsonism features along with that patient is having large amplitude movement. That is off weaning of dystonia. So in this setting, patient is having both kind of dyskinesia during on and off. This is called diphasic dyskinesia. It is very difficult to treat. And weaning of dystonia. So at the off period, patient started having the dystonia that is involving the limb space and other parts of the body. This is called weaning of dystonia. So after starting the drug, patient will have these kind of dyskinesias. One is peak dose dyskinesia, that is during the on period, patient is having abnormal movement. Diphasic means both on and off during this period, patient is having dyskinesia. Weaning off dystonia means only during the off period, patient is having dystonia. How to manage? In a peak dose dyskinesia, you need to reduce the dose and you need to stop the long-acting levodopa supplementation, and better you avoid COMT inhibitor and MAO-B inhibitor. In that place, you can add dopamine agonist, and amantadine would be the better drug. In off-dose dystonia, you can increase the dose of levodopa. In diphasic dyskinesia, it is very difficult to manage. Better, ideally, they advise deep brain stimulation, or you can increase the dose of levodopa. So this is the flow chart. So you started the levodopa therapy. Patient started having motor fluctuation in the form of on, unpredictable off, and delayed on. All those things, as I told earlier, need to manage by altering the drug doses, frequency, and add-on therapy. Okay. If severe fluctuations are there, not able to manage with the drugs, you can tell them to undergo surgical intervention. If a patient is having dyskinesia, as I told, peak dose dyskinesia, weaning up dystonia, and diphasic dyskinesia. In this setting, you need to avoid sustained release preparation. You need to stop MAO and COMT inhibitor. In that setting, you can add dopa agonist and amantadine. If that also not controls, you can add other newer novel drugs like zonisamide, clozapine, quetiapine. Next slide. So next come to the surgical aspect for motor complications and for the tremors. So if a patient is having severe dyskinesias, severe motor fluctuation, Despite of optimization of therapy and very drug resistant tremors, in that setting you can opt the patient for surgical interventions like deep brain stimulation, pallidotomy, or transcranial magnetic stimulations also. So before I was referring the patient for surgical intervention, you need to rule out other causes. So atypical Parkinsonism patients will not be referred for surgical intervention. And if a patient has secondary Parkinsonism also, there is no role of deep brain stimulation. If a patient is having severe dementia, already stage 5 of ONS scaling of Parkinson's disease, and patient is having severe psychiatric issues or suicidal tendencies, in that setting also, deep brain stimulation will not be beneficial. These are all the exclusion criteria for deep brain stimulation. These are the varieties of intervention: deep brain stimulation, carbidopa intestinal gel preparation, apomorphine subcutaneous infusion pumps, pallidotomy, and subthalamiectomy. These are the surgical intervention. Just you remember the name. Okay? So after procedure, patient will have reduced off time and increases the on time, and troublesome dyskinesia will disappear. So big effect would be you can reduce the dose of the drug, you can decrease the frequency of drugs, and side effects like dyskinesias will not be there. Only problem is cost, and rechargeable batteries will be there. We need to replace the batteries every 10 years. And sometimes if the battery fails, patient will have sudden onset akinetic Parkinsonism. And in the tier 2 cities, it is very difficult to do all these settings. You need to refer the patient for higher tertiary centers. Next slide. So this is the spectrum. So if a patient is having atypical symptoms, dementia, predominant gait symptoms, there is no role of DVS. Okay. If a patient is having motor fluctuations, levodopa sensitivity, if the patient attender know that uh, in the realistic expectation, so not behind that, they're willing. In that setting also, you can refer the patient for deep stimulation. So other symptoms like non-motor symptoms also very important. Most commonly we see constipation. You can use osmotic laxatives, high fiber diet, probiotics. In most of the patient, Parkinsonian patient will have siluria. You can give chewing gums or hard candy to chew, or botulinum toxin can be given to salivary gland, and you can give glycopyrrolate 1 milligram thrice a day. Rhinorrhea due to the autonomic dysfunction, patient will have gustatory rhinorrhea. In that setting, you can give ipratropium nasal spray. For sexual dysfunction, it can be both hypersexuality or autonomic dysfunction in the form erectile dysfunction. In hypersexuality, most commonly seen in younger men, and these levodopa will also causes this kind of abnormal symptoms. It can be treated with a dopamine agonist or surgical intervention. Erectile dysfunction, same, you can give sildenafil or valdenafil. Daytime sleepiness, again, you need to explain the sleep hygiene techniques. Um, Dopamine agonist also causes excessive day sleepiness. Modafinil or selagelin would be the better options in a patient with excessive daytime sleepiness. And for rapid eye movement, that is REM sleep behavior disorders, you can give melatonin or clonazepam. So whenever you're using benzodiazepine, be cautionary in the elderly patients. Nocturnal echinacea, as I told, you can use the sustained release levodopa or roticotin patch. For orthostatic hypotension, again, you need to address the pharmacological drugs, and you can give metodrin or fludrocortisone, and you need to explain regarding the exercises. And depression, anxiety, psychosis are most commonly seen. You need to do a cognitive behavioral therapy. SSRIs or SNRIs would be beneficial. So in a Parkinson's patient with psychosis, you need to be very cautious, because if you give antipsychotic, Parkinsonism will worsen. If you don't give, again, it would be problematic for the patient and neighbors also. So low dose pimavanserin, quetiapine, or clozapine can be given, because these have least extrapyramidal symptom. For fatigue, you can give methylphenidate and amantadine, because these are glutamatergic action. Parkinson dementia, you can give cholinesterase inhibitors like rivastigmine, donepezil, and memantine can also be given. For swallowing dysfunctions, you need to explain chin tuck posture. That is straight neck with chin up posture. In that setting, swallowing would be much beneficial. Or you can tell the patient to rotate the head towards the weak side. So that will also help the swallowing. You need to adjust the food. That is semi-solid food would be or liquid food would be the better. Better you avoid high calorie or high protein diet. So you need to give the Parkinson's. This is called Parkinson diary. So every early patient to be filled. So in which what all the medication have been taken, meal what time patient taken, how is the sleep, what is the on duration, what is the off duration, whether patient is having any dyskinesia or not. Because in home we cannot able to monitor. So if the patient is educated enough to fill these things, it would be better to monitor from the phone only. So come to the last part, that is atypical Parkinsonism management. Is very difficult because the most of the treatment would be mainly symptomatic, because levodopa sensitivity only 30 to 40% of the patients. Up to 2 grams you can give. Meanwhile, you need to see for orthostatic hypotension. In MSA, again, in MSA patient, already orthostatic hypotension will be there. Again, if you give levodopa, that will worsen. So in that setting, you can use dopamine agonist or amantadine. In this setting, surgical intervention not advised and not beneficial also. And other measures like to maintain the orthostatic pressure, you need to explain the exercises, that is head up tilt, elastic stockings, adequate salt intake, or you can give midodrine or fludrocortisone tablet also. For postprandial hypertension, you can give octreotide. For excessive nocturnal polyuria, desmopressin spray will also be available and tablet is also available. For bladder symptoms, you can use oxybutynin tablet 2.5 mg or other like solifenacin can also be used. If a residual volume is more than 100 ml, in that setting, you need to advise for intermittent self-catheterization. For REM behavioral disorders, as I told, clonazepam or melatonin can be helpful. And most of the OSA patient, due to the autonomic dysfunction, will be having obstructive sleep apnea. So CPAP is advised. So again, PSP, atypical Parkinson, 30 to 40% patient will have benefit from the levodopa. So mainly you can give amitriptyline for the pseudo or emotional incontinence, botulinum injections for the dystonia, and patient will have very poor prognosis. Mean survival rate expected 8 years. Corticobasal degeneration, again atypical Parkinson, least benefit with the drugs. And for dystonia, you can use the toxin, botulinum toxin, clonazepam for the myoclonus, because patient will have asymmetrical cortical atrophy. Patient will be having myoclonus, hemiparesis, hemidystonia syndrome. Is also very carries very poor prognosis. Survival rate expected up to 7 years. And Lewy body dementia, again, this is also atypical Parkinsonism group of disorder. Better you can give cholinesterase inhibitors like donepezil or rivastigmine or memantine. Next
Hello,
slide.
sir. Sir, the slide was not available. Can you repeat, sir?
This is shall I
This
repeat
slide.
this?
Yes, sir.
In a case of Lewy body dementia, better would be cholinesterase inhibitor like donepezil or rivastigmine. Better you avoid levodopa, because in a Lewy body dementia, predominant clinical symptom would be psychosis. Again, if you give levodopa, that will worsen. Better avoid dopa supplementation in this setting. So predominantly non-pharmacological intervention like physiotherapy, caregiver training, antipsychotics again should not be given. If in case very severe, quetiapine can be given at the lower dose. As I told earlier, again, levodopa is beneficial, but the problem is psychosis. Patient will end up with psychosis and hallucination. Better you avoid dopa agonist or levodopa supplementation. For RBD, you can give melatonin. So recent updates we'll see. What three updates are there? Uh, Synuclein, it can be detected in the CSF or the serum by doing the RT-PCR, that is RT-quick technique, PCR based assay. This is a novel serum marker, has great potential. It can be used as a biomarker for both diagnosis and the management of synucleinopathies. Okay, this is a recent update on Parkinson's disease. And the device is called device name not mentioned. Predominantly it is based on the motor action potential, that is acceleration potential. It varies from age, sex and severity of the index. So early part of the disease, by seeing this motor action potential, we can diagnose or we can screen the future risk of Parkinson's disease. And newer drug is extended, that is newly released extended release carbidopa levodopa. It contains both kind of molecule. One is immediate release, that is 25% of the levodopa will be released immediately, so it will take care of acute symptom, and 75% of the dose will slowly releases. So as we use routinely either immediate release or extended release, but the newer drug is IPX 203, it has both component. One is immediate release and one is extended release. So not yet come to the market, but it has FDA approved. Thank you. Any doubt?
Sir, how is deep brain stimulation done, sir, and how does it help here?
Hello,
Hello, sir.
I'm
Hello.
audible.
Yes, sir.
Yeah, tell me.
Sir, how is deep brain stimulation done, sir, and how does it help in Parkinson's disease?
Mechanism you are asking?
Yes, sir. Yes, sir.
Mainly it will increases the basal ganglia, that is basal ganglia, midbrain, all those things are dopaminergic results will be there. By activating the substantia nigra, it will increases the dopaminergic drive.
Okay, sir. Sir, we'll end the session.
Hello.
Hello, sir.
Tell me.
Sir, we'll end the session. Sir. Thank you, sir.
Okay, any other doubts?
Sir, no, sir.
Hello.
Hello,
Okay,
sir.
okay.
Yes, sir. Thank you, sir.
Okay.